Hi everyone, welcome back to your lecture session on overview and integration of cellular metabolism. We are almost at the end of 4th week and this is the last topic that we will be covering on carbohydrate metabolism. Definitely we will be covering more about carbohydrate metabolism when we go into the integration and overview of integration metabolism phase. But for now, our today's topic is diabetes mellitus and the metabolic alterations in diabetes mellitus. Now, as all of us are aware, the diabetes mellitus itself is such a huge disease, and there are specialties and super specialties and thick books that are written on the topic. So, the overview of diabetes mellitus will be what that is we will be covering in this lecture, because if we start getting in deep into each and every topic, the entire lecture series can be covered by just taking diabetes, right. So, that being said, keeping that in mind, we will be discussing our lecture today on the following headings. We will be learning how to diagnose, how is the diagnostic criteria of diabetes mellitus. We will be learning what is the difference between type 1 and type 2 diabetes mellitus. We will also be learning what are the metabolic alterations, that is our main focus in diabetes mellitus, as well as we will also learn what is the metabolic basis of the diabetic complications, alright. So, this I will start with this slide, which is actually the recall slide from the previous class where we discussed the regulation of blood glucose, right, blood glucose homeostasis, and over there I discussed these are the few check milestones which we need to keep in mind for diagnostic as well as for multiple choice questions, right. So, I discussed that this whole thing will be discussed in much detail in later class, which is today's class, alright. So, I hope this slide is very familiar with you. With this basic knowledge, let us go ahead. Now, what is diabetes? Since diabetes is a disease, a strict definition cannot limit because it has got so many things, but just for sake of stating what the disease is to us, we can say diabetes mellitus is a chronic metabolic disorder. Chronic means it develops over time. Chronic metabolic disorder characterized by what is the problem? Excess glucose. The only and only culprit is high blood glucose in blood and urine. Okay, this thing often it is missed. All right, due to what is the reason? Defective insulin action or deficiency in its secretion. So, either insulin is less or insulin is more and it cannot act, which leads to the problem of increased blood glucose and urine glucose, and it develops over time. Okay, so, this is the whole definition or statement about diabetes that we need to know. Now, regarding the diagnostic criteria of diabetes, the diagnostic criteria that we all follow in standard textbooks as well is American Diabetes Association criteria. It was coined in 2011 and it remains same till date, that is 2023. You can check the same information in American Diabetes Association website as well. So, what are the cutoff points or the criteria based on which diabetes is diagnosed? Well, the whole thing not only diagnoses diabetes, but it also gives us an idea about the normal blood glucose level, what is the pre-diabetic condition, what is diabetes, right. So, you can find out the normal means we are a person or an individual does not have any disease. So, what are the cutoff limits? In fasting, whenever the person has not taken anything, after overnight fasting, that is the blood glucose level should be below 100. Mind it, below 100 means up to 99. You see, loosely we often say it is 70 to 100, but according to American Diabetes Association, that is ADA criteria, we often abbreviate it as ADA, it is pre-diabetic. So, the 100 mg per deciliter falls under the lower limit of pre-diabetic. Again, I told you in many textbooks, especially in older textbook, the criteria that still holds true, or and even in many medical undergraduate textbooks, it is 110 mg per dl, right. But if we follow, we have to follow one standard criteria, we follow ADA criteria and it is up to 99. So, 70 to 99 is the normal fasting blood glucose level. Again, one term I would like to request all of you who are listening to this lecture, henceforth do not use the term sugar, right. Blood sugar is a misnomer, because we are only dealing with diabetes by the level of blood glucose. Sugar means many other carbohydrates other than glucose, right. So, even if mistakenly I say sugar, you know this, that I am wrong. What I mean is glucose. So, that being said, the normal blood glucose level fasting is up to 100, so 70 to 99. And what is postprandial? We have heard this term PPBG or PPBS, for example, postprandial blood sugar. The correct term is postprandial blood glucose. The correct cutoff limit is up to 140. Unit for everything glucose is milligram per dl, right, up to 140. The lower limit being 70. So, 70 to 99, 70 to 139, right, 140 again falls into pre-diabetic territory. And this pre-diabetes, what is pre-diabetes? It means a state of altered metabolism where it is neither normal nor a state of frank disease, right. So, what is the criteria or cutoff criteria of frank disease where we definitely need treatment? This is 126, more than equal to 126. So, 126 mg per dl is diabetic, and for postprandial it is 200. Well, we do not see the word PP, okay, we see OGTT. So, what is this? This stands for oral glucose tolerance test. Oral glucose tolerance test. What is done? In postprandial blood glucose, what used to be done with the dictum is we ask a patient or a case or a normal person who has come for routine blood glucose checkup that you take a meal and after 2 hours you check the blood glucose, right. In oral glucose tolerance test in OGTT, there is a finite amount, that is 75 gram of glucose is asked to be taken in case of a adult patient, and this actually varies depending on his weight, but the standard for a standard adult, healthy adult, 75 gram of glucose. After 2 hours the whole value is taken. So, it gives a uniform idea, because suppose I am taking some idli and someone might be taking 10 rasgulla, the value of postprandial per se might be erroneous. So, OGTT gives us an uniform idea. So, that being said, that is after meal, 2 hours after meal, the cutoff is 200. So, considering the pre-diabetic state, that is the condition in which I have abnormal metabolism, but still the disease can be reversed by lifestyle modification, and there are many things. I mean, I have not reached the alarming stage. The cutoff to that pre-diabetic state is 100 to 125 in case of fasting, and in case of OGTT it is 140 to 199, units being mg per dl, milligram per deciliter. Very important. The cutoff criteria is so important, that is why I am spending so much time and we are dedicating so much time, because you need to learn this, right, and you need to remember it by heart. Diagnostic, everything, multiple choice question, exam result, common knowledge, everything, right. One additional criteria is there, that is regarding the parameter A1C, glycated hemoglobin. We will be discussing that separately in an upcoming slide, but for now just know this, that lower cutoff for normal, I mean the higher cutoff for normal is 5.7, the unit is gram percent, okay, or gram per deciliter. Unit of blood glucose was in mg, this is gram, and for diabetes the cutoff is above 6.5, more than equal to 6.5. So, 5.7 to 6.5 falls in pre-diabetic state, okay. So, this is all about the diagnostic criteria of diabetes mellitus according to American Diabetes Association guidelines, okay. So, let us move forward. So, how can we classify diabetes? Earlier, or if we see textbooks in, I mean older textbooks, we will find the names are actually different. Earlier the nomenclature of diabetes or the type of diabetes was given based on the age, either it was based on age or the type of therapy which was used to treat the diabetes. Nowadays it is not used, that dictum is not used nowadays. We now name the diabetes types based on the pathogenic process. So, now it is actually type 1 and type 2, it is actually very easy, right. I will discuss in more details what was the earlier names and what are the differences very soon, but you should know that in both the types, be it type 1 or be it type 2, the problem lies in abnormal glucose homeostasis. So, the class that we had preceding this class, that is blood glucose homeostasis, regulation of blood glucose, that whole thing is jeopardized. That is why blood glucose goes up. I told you, any problem, only insulin is there to keep the blood glucose down. So, any problem in that hormone is a single player which keeps the blood glucose in control. So, any problem, blood glucose will go high, right. So, let us see what are the differences between the two varieties of diabetes, right. So, we have the features over here as well as type 1 and type 2. So, previous name for type 1 diabetes was IDDM or insulin dependent diabetes mellitus, because it needed only and only insulin for therapy, right. Without insulin, type 1 diabetes cannot be treated. Also earlier, depending on the age of onset, I told you, so it was juvenile onset diabetes mellitus. It was also known as juvenile diabetes mellitus. Well, mind it, nowadays also we loosely use this term, but strictly speaking, correct term is type 1 diabetes mellitus. Okay, these IDDM, juvenile diabetes mellitus, often means one and the same thing, but if you are to choose the right thing, you need to state type 1. Similarly, in type 2, it was known as NIDDM, non-insulin dependent diabetes mellitus, and since it happens in older patients, it is also known as maturity onset, right. So, generally it happens in older patients, so maturity onset diabetes mellitus. Now, since depending on the nomenclature, we already know what can be the next difference, that is the age of onset. The age of onset in type 1 is usually in case of small children or below puberty, for that matter, in pediatric age group. Now, so during childhood or puberty, there is an exception. The disease specifically that is mentioned under LADA, that is latent autoimmune diabetes in mellitus, means the pathogenesis. Since now we are classifying diabetes based on pathogenesis, now this type, the LADA variety, is actually the pathogenesis is autoimmune, but we have to consider it in type 1. If it were, we were doing in based on the earlier classification, we had to say, okay, since it happens in adults, it would have been type 2, okay, I mean the non-insulin dependent. But now, since the classification is based on pathogenicity, we need to consider LADA in type 1, because both in case of type 1 and LADA, the pathogenesis is autoimmunity, okay. And again, the age of onset for type 2 diabetes is old, individual old cases, more than 35 years. What is the exception? Maturity onset diabetes of the young. We are not going to the details of the pathogenesis, but the insulin resistance is the pathogenesis that actually are found in these cases, but these are patients that are actually younger patients. So, earlier they could have been considered in juvenile, but no longer. Now, we are strictly considering on the pathogenesis, right. So, regarding pattern of onset, they develop rapidly. Type 1 suddenly develops. The underlying pathogenesis may go on for years, but the symptoms are all of a sudden, whereas it's very slow in case of type 2 diabetes mellitus. Regarding the prevalence, what is the prevalence? If we are considering 100 patients of diabetes, only 10% have been found to be of type 1. More than 90% or almost 9 out of 10 patients are type 2, right. Considering the genetic predisposition, means you often hear my maternal uncle has diabetes, my mother has diabetes, so now in being that part of the family, you are also predisposed to diabetes. So, what type of diabetes are they referring to? They are referring to type 2, because genetic predisposition of type 2 diabetes is very strong. It is not that much strong in case of type 1 diabetes, okay. It is moderate, it is there. I mean the tendency to have autoimmune destruction of pancreas, which is the main pathogenicity, can happen. There may be a genetic predisposition, but mostly the factors that help in development of insulin resistance are there in type 2. Nutritional state at the type of diagnosis. How will the patient look like? The patient of type 1 diabetes will look like lean and thin, undernourished, okay, skin and bones, if you can define that thing, and it is mostly obese, fat in case of type 2 diabetes mellitus. Again, what is the biochemical defect? Autoimmune destruction of beta cells in 90% of the cases, and in remaining 10% of the case it is still not known. It is still research is being pursued. What is the reason of those cases in which there is no destruction by autoimmune mechanism, right? Whereas In case of type 2 diabetes mellitus, it is the insulin resistance combined with the ability of beta cell to produce inappropriate amount of insulin. So, first insulin resistance develops and then at the later stage beta cell dysfunction develops, right. So, as you have guessed rightly, plasma insulin is almost low to absent in case of type 1, in case of type 2 it is high in early stage. There is something known as compensatory hyperinsulinemia, but as we go on the beta cell dysfunction happens and again it is low, right. So, the acute complications being diabetic ketoacidosis, it is abbreviated as DKA. In case of type 2 diabetes mellitus, it is known as hyperosmolar non-ketotic coma, HONK, okay, hyperosmolar non-ketotic coma, HONK. Frequency of ketosis very common. Ketosis, a mild amount of ketosis may be found in type 2 diabetes mellitus, but is mostly common in type 1 diabetes mellitus, alright. And regarding the treatment, insulin is always needed, oral hypoglycemic drugs are ineffective, and in this case lifestyle modification, that is diet, exercise and oral hypoglycemic drugs are quite effective, and insulin may also be required in severe cases, right. So, this is the natural course of the type 1 diabetes. Let us see what happens. So, initiating event is there is an exposure to any virus or toxin that will lead to the autoimmune trigger, and in course of time it will slowly decrease the beta cell. Mind it, if we just look at the insulin secreting capacity, when the beta cell destruction is going on, still the pancreas secretes adequate amount of insulin so that the disease is undiagnosed. Now, suddenly when the destruction has reached a certain level, suddenly the symptoms develop, there is ketosis, there is hypoglycemia, all the features of type 1 diabetes, and ultimately the features, I mean this is the case that happens, okay. And in case of type 2 diabetes mellitus, what happens? Initially an obese patient, starts with obesity, right, patient starts developing insulin resistance and it can run up till many years. Then what happens? Patients are diagnosed. When patients are diagnosed, initially in initial stage, I told you there is something known as compensatory hyperinsulinemia. So, blood glucose rise is not that much, but ultimately in the long run it will be very high, right. So, next, so this is all about the natural course of type 1 and type 2 diabetes. Now, regarding another parameter that we just discussed, that is a hemoglobin A1C or HbA1c. What is HbA1c? You see, whenever there is glucose in the system, it has a tendency to attach to any non-carbohydrate molecule, right, that is known as glycation, and that increases and that corresponds to the amount of blood glucose that is present. So, when blood glucose is very high, there will be glycosylation of multiple products, and that is a covalent bonding. However, there is also something that is non-enzymatic covalent glycation, okay. This is also proportionate to the amount of blood glucose that is present, and what ligand or what moiety we are focusing over here, that is hemoglobin. So, it means normally hemoglobin is attached with glucose to form HbA1c. It is normally below 5.7 gram%, but when it is very high, so when glucose is very high, so the amount of glycation also increases. So, HbA1c level will be high. Now, why HbA1c is actually very useful? You see, blood glucose level can go up and go down very suddenly depending on our metabolic activity, depending on taking of drug, or depending on whether somebody is injected insulin or not. But once HbA1c is formed, once a hemoglobin is glycated, the lifespan of an RBC is 120 days. So, the status, if once today is glycated, it will run for the next 3 months. So, even if today my glycated hemoglobin level is very high and now my blood glucose level is more than 200, my glycated hemoglobin level is more than 6.5, right, I fit in all the criteria of get diagnosed by diabetes mellitus. Suppose I am taking insulin shots along with that. So, I take my insulin, now I get my blood tested, my blood may show 120 mg per dl. To a physician who does not know that I have a history of diabetes mellitus, I may appear to be absolutely normal, right. So, the glucose level can be fooled For example, even if I don't take insulin shot, if I skip my meals, at some point of time all my blood glucose will be used up and all the glucose level will fall, and that means a fall slow blood glucose level. This, and similarly it can in opposite direction also. Suppose I take 10 rasgulla, there is a sweet dish, and immediately I test my blood, the blood glucose level will be falsely high, but the glycation of hemoglobin cannot be fooled, because once it is glycated, it will continue, the state will be continued for next 120 days. So that is why even if fasting and postprandial blood glucose are essential, HbA1c is also one diagnostic criteria according to ADA guideline, the cutoff point being more than 6.5, and we have to ensure that where the laboratory where we are measuring has to be standardized using NGSP, that is National Glycohemoglobin Standardization Program. It is a type of accreditation program by which they certify whether the lab is actually using the correct protocol, so that basically what it means, the reliability of the HbA1c result from the lab. So this is all about HbA1c that we need to discuss in this class regarding metabolic alteration of diabetes mellitus. Now what is the exact metabolic alteration that happens, right? Two things. Basically what the roles of diabetes mellitus, they are what are the roles of insulin, they are reversed, because there is either absolute or relative, means functional deficiency of insulin. So there is decreased glucose uptake, or that leads to an increased glucose production. The uptake happens in muscle and adipose tissue on action of insulin, and glucose production happens in liver. So if the glucose uptake is not occurring and glucose is being continuously produced in liver, ultimately there will be hyperglycemia. So this is the inter-tissue relationship in diabetes mellitus. So what happens, see, in type 1 diabetes mellitus, basically glucose level is low. Okay, so when glucose level is low, cells cannot uptake glucose. Okay, so when insulin is deficient, cells cannot uptake glucose. So intracellularly a cell cannot sense, it senses glucose deficiency. So it tries in every way to compensate for that by undergoing what is known as gluconeogenesis. So all the substrates for gluconeogenesis are being pushed towards the liver, and there is increased production of glucose, okay, because there is a deficiency of insulin. Now what happens inside the cells, since glucose is absent, alternate sources of metabolism, storage sources are broken down to produce energy, that being fatty acids. Now fatty acids when broken down, you will be reading all this very soon, so I am not going into much detail. Fatty acids when they are broken down, they produce acetyl coenzyme A. This acetyl coenzyme A cannot enter the TCA cycle due to deficiency of oxaloacetate. Why? Because oxaloacetate is a substrate for gluconeogenesis, it is being used up. So TCA cycle is not functioning, that is why all the acetyl coenzyme A is now diverted towards production of ketone body. So there is excess glucose and there is excess production of ketone body. Okay, so this is the thing that happens in cell as well as in liver, that leads to production of diabetic ketoacidosis. Well, in case of type 2 diabetes mellitus, the mechanism is almost similar, but there are some insulin that actually in initial stage, of course, there are compensatory hyperinsulinemia, and in course of time when insulin deficiency happens or beta cell dysfunction happen, often cases of type 2 diabetes mellitus can mimic type 1 diabetes mellitus, but the amount of ketosis, ketone bodies produced are much less compared to type 1. All other pathogenesis remaining same, increased gluconeogenesis, increased glycogenolysis, and that leads to hyperglycemia. Okay. So these are the major metabolic changes in diabetes mellitus. So what happens in carbohydrate metabolism? Glucose uptake is reduced by muscle and adipose tissue, there is increased glycogenolysis and gluconeogenesis. Clear? What we will be discussing in lecture session ahead, now moving forward, that is what the alterations regarding lipid and protein metabolism. So just for now you should know this. In case of lipid metabolism, there is increased fat breakdown, increased fatty acid oxidation and production of ketone bodies in the liver. These are all catabolic processes. Insulin is an anabolic hormone, it helps in all the metabolic pathways that are anabolic. So when it is deficient, all the catabolic processes are upregulated by the counter-regulatory hormone, that is glucagon. Same happens in protein metabolism, decreased protein synthesis and increased protein degradation. So, once you understand the concept, everything will become very clear. So, what is the signal or what is the basic alteration in the hormone signaling that happens in diabetes mellitus? Okay. See, in liver what happens? Liver is supposed to regulate, it acts as a storehouse of glucose. I told you regarding the mechanism of hexokinase and glucokinase. So, mainly it regulates the pathway of glycogenolysis and gluconeogenesis. So, if that is under imbalance, hyperglycemia will occur. How it occurs? Since there is decreased secretion of insulin, insulin has got an inhibitory effect on glucagon. Glucagon has always got a tendency to increase blood glucose, okay, because increasing blood glucose is an emergency mechanism. It always tries, because not only there are multiple other factors by which blood glucose rises, that we already discussed in the previous class. So, if inhibitory effect of insulin is gone, the glucagon will be more and more, that will lead to increased glycogenolysis and gluconeogenesis, and that will release more glucose into the bloodstream and increased plasma glucose will happen. This is the alteration that happens in liver. Similar alteration also happens in muscle and adipose tissue. Lack of insulin leads to all the catabolic pathways. So, proteins are broken down to form gluconeogenic, substrates for gluconeogenesis, that is glucogenic amino acids are produced, and that also increases plasma glucose. Similarly, in adipose tissue, lack of insulin means lack of glucose uptake. From plasma, glucose are taken up in cells. If insulin helps in that. If there is no insulin, there will be no glucose uptake, and ultimately plasma glucose will rise. So, now let us look at the complications of diabetes. Mind it, I have not gone into details regarding the clinical features of diabetes mellitus, that is polyphagia, polydipsia, polyuria and polyneuropathy. So, let me discuss in brief right over just before going into the complication, right. Diabetes is one very important symptom of diabetes is polyphagia. Patient suffers from increased hunger. Why that is so? You see, blood glucose has got a tendency to regulate the hunger center, right. Means what? When we have got when we are well fed, means the hunger center is suppressed, because the satiety center is also addressed. You mean to say, just listen to me once, when there is increased blood glucose level, the body does not need more glucose. So, there is no need to eat. When there is low blood glucose, the hunger center is stimulated, because the inhibition of satiety center over the hunger center is gone, and we sense to take more and more food. That happens in case of normal individual. But when a patient is having diabetes, means insulin is not acting, then the person feels as if he needs to take more and more food in spite of having full stomach or in spite of having high blood glucose. So, that is one pathogenicity, both hunger and thirst, that we need to keep in mind. The same mechanism is happening for food intake as well as water intake, and since there is more and more glucose in blood, there are multiple osmotic complications that leads to polyuria. Now, going into the complications of diabetes mellitus, the major complications are addressed by three mechanisms. Number one, formation of advanced glycation end products. Number two, sorbitol pathway, that we already discussed in galactose and fructose metabolism, and number three is the production of reactive oxygen species. So, the first mechanism is advanced glycation end product. What is glycation? I told you, covalent non-enzymatic attachment of carbon to multiple compounds, right. So, there are some compounds to which if glucose or any carbohydrate is added in excess, for example, excess amount of glucose is attached to some compound such as few amino acid, few protein, few fat, lipid particles, they actually trigger a chain of immune reaction which leads to a destruction in blood vessel. Specifically, the interaction between those advanced glycation end products and their receptors. Their receptors are known as RAG, that is receptors for advanced glycation end product. Minded, this is itself a huge topic, so, and if you are interested, there are references in the reference section, you can read it, but for now just know this: excess glycation of certain products leads to microvascular complication by interaction with the receptors, and whole thing is mediated by inflammation and pro-inflammatory cytokines. The next mechanism I already discussed in fructose and galactose metabolism, that is how there is increased sorbitol inside the cell, because in case of these slides are common to those classes, right. So, I will not be covering these in details because you already know, and I already told you, because we will be referring these slides again in diabetic complications. So, the thing is, the enzyme sorbitol dehydrogenase is absent in the organs of lens, retina, nerve cells and kidney. That is why the sorbitol, when it is formed in case of excess blood glucose, cannot be washed out, and they lead to all the complications of diabetes, that is diabetic retinopathy, diabetic neuropathy, diabetic nephropathy, so on and so forth. And ultimately, lastly, that is the major complication, which is the triggering mechanism for all other microvascular complication, is reactive oxygen species mediated damage. I already discussed about reactive oxygen species during HMP shunt and glucose 6-phosphate dehydrogenase deficiencies. You already have some idea. Basically, what happens is, this excess amount of sorbitol and an imbalance between NADH to NAD ratio, that is redox imbalance, that happens in diabetes mellitus, leads to an increased amount of reactive oxygen substances, that leads to something known as oxidative stress, and that oxidative stress actually hampers with multiple normal cellular mechanism, that is cellular proliferation, apoptosis, cellular that leads to dysfunction of cell and damage, and ultimately that leads to all the microvascular complication. And along with that, an excess of advanced glycation end products, excess fructose, that is bypassing the glycolytic pathway and entering into the cell, creating an hyperglycemic state, and also excess sorbitol, that leads to the formation of all the problems, including problem in eye, that is cataract and other electrolyte imbalance. So, this is the conclusion, that this class has covered the diagnostic criteria of type 1 and type 2 diabetes mellitus. We have also discussed what are the differences between type 1 and type 2 diabetes mellitus. We have also covered what is the natural courses, metabolic changes, the basis of metabolic complications, as well as the basis of clinical features in a brief. So, these are my references, and you can read them at your will, and this is the end of it. We will be moving very soon to lipid metabolism in the next class. I thank you for your attention.